going to go ahead and get started. So good morning. Thank you all for being here. This is our virtual caregiver workshop, Preserving a Loved One's Dignity When Caregiving Gets Messy. My name is Candace Christensen, and I am the coordinator for the Caregiver Coalition of Northeast Florida. So I am super excited that we're putting on today's conference, and it's focusing on those parts of caregiving that can be messy and can be kind of hard to talk about. So we really just wanted to create a safe and non-judgmental space for you to learn and ask questions about these difficult topics, and hopefully leave with some tools and coping strategies that can really build your confidence in being a strong and a capable caregiver. So before we get into it, I do have a short message from a couple of our 2021 sponsors.
How's everybody doing?
Hey guys.
Hi.
It's time to lean on each other.
All of you guys, so much great support.
And laugh with each other.
Cheers.
Let's do it together with caregiving chats and more. Come find us at aarp.org/near you.
My wife, I call her a drill sergeant. She gave me the inspiration to build myself up. I need to go on dialysis. Florida Blues, they gave my wife good information. What I ate, how she cooked, and everything. In fact, if I go to the store and buy something today, she'll get it and read it and say, you can't have this. That's why I think I'm where I'm at today.
All right, so I want to thank our 2021 gold sponsors, Florida Blue, Baptist Agewell Center for Senior Health, and Community Hospice and Palliative Care, as well as our renewing silver sponsor, AARP. So they all have generosity and this dedication to caregiving.
Let's do it together.
For them. So a couple more really quick items before we get into our first speaker. The session is being recorded, so if you can keep your camera off and your microphone muted, it'll make it a little bit easier and minimize distractions throughout the workshop. We will be posting the workshop to our YouTube channel and our website. If you have any questions during the presentation, you can type those into the chat box, and we will make sure that they get answered when we reach that Q&A and expert panel discussion towards the latter half of our workshop. At the end of the session, I am going to put up a quick poll, and that's just letting us know what you liked and what you didn't like, and we can just make sure these workshops are the best that they can be. And then lastly, in case we run into technical difficulties, I'm going to try and resolve them as quickly as possible. So, to start our workshop off this morning, I wanted to introduce Jamie Glavich. Jamie, you can turn your camera on. Jamie is a certified dementia practitioner, and she is the founder and owner of Almost Home Senior Services here in Jacksonville, Florida. She directs programs of care at her 2 assisted living homes and an adult daycare center. And she's really instrumental in serving Florida's Alzheimer's care community. So Jamie, I'm going to turn it over to you. Thank you so much for being here.
Thank you. And you'll be clicking through the slides, right, for me? Okay, I just wanted to make sure we didn't get to practice that. Hi, good morning, everybody, and welcome. I'm so glad to see so many people joining us. This is wonderful. I will speak a little bit about normal aging practices, but my expertise is really in Alzheimer's and dementia care. But we can learn a lot today by learning different communication techniques and the disease process and how to communicate with people. And hopefully, no questions are off limits at the end of this, so feel free to ask anything. I've had about 30 years worth of experience, and I hope I can help you a little bit with your caregiving journey. Okay. Next slide, there we go. No two people experience Alzheimer's and dementia the same way, or even aging. We all have different medical backgrounds, our health issues and cognitive issues, and the cognitive impairment and our health issues really steer how we grow old. There's several approaches to caregiving, and no two approaches might work all the time. So we learn different types of approaches, and there's no one specific approach in caregiving for somebody with Alzheimer's. We have sometimes have to go into a whole bucket of things to use at one time. It's kind of a trial and error too. preserving a loved one's dignity when caregiving really does get messy. Somebody with Alzheimer's or dementia and advanced aging, they start needing a lot of personal care. They need a lot of hands-on help with personal personal issues like bathing and dressing and grooming and going to the bathroom. And you really have to, you end up getting into their personal space, and they don't have that privacy anymore. And it's very hard when I hear a lot of stories of sons trying to give mothers baths, or husbands, taking care of their wives in the shower, or trying to change their adult brief. And it's really hard on the caregivers. And it's, I feel like it's demeaning for both caregiver and the person that's suffering with any kind of memory loss, cognitive issues, or advanced health issues. Okay. So we kind of get to know our loved ones more intimately, or the person we're caregiving for, more than ever. So their abilities and disabilities really do change daily, and sometimes even hour to hour. When we're working with Alzheimer's patients or people with cognitive impairments and dementia, I kind of describe it as like a light switch that goes on and off, because sometimes they can do something and 2 hours later they might have totally forgotten how to do that activity. So as caregivers, we really need to learn how to be flexible. We really get creative juices going to try and figure out things. And we learn how to have really good problem solving skills. And we try and learn those, and hopefully going to seminars like this and talking to the experts and other professionals for any kind of ideas on how to have the best caregiving experience we can have. And some things to remember when we're approaching any kind of action is to be very supportive of your loved one, and really you kind of have to supervise their activities. We're concentrating on process, not always the result, but we will get there. And really be realistic. Sometimes you can't get everything done, and you have to kind of relax through this. Okay. When we're doing day-to-day caregiving activities, we learn some skills. One of the things is to really break down the activities into small steps. Let the person with Alzheimer's or memory loss know that they're really needed, and they're still wanted, and they're still able to do things. They're still loved, and it's hard not to criticize sometimes when somebody does something wrong, but you can't criticize them. That's a dignity issue too as well. We want to make sure that we're not overcorrecting them, and kind of helping them again, and supervising at a distance and being supportive of what they're doing. Reality orientation doesn't always work. We learn when we're caregiving for somebody with memory loss that we actually get into their reality space. And also as caregivers, remember, you can't do everything, and sometimes you have to choose what you're going to do for the day or for the moment. Day-to-day communication for someone with dementia, they do end up having some problems finding the word. And we always have that tip of the tongue syndrome, even in normal aging, and trying to communicate. Sometimes they use familiar words repeatedly over and over. They mix up words together, and we end up calling it like a word salad, and invent new words. Sometimes somebody with Alzheimer's gets to the point where they might mumble, or their speech is not clear as well. They lose their train of thought, and a lot of them do revert to their native language, even if they've spoken like English for the last 30 years. Maybe they were raised, and I've had multiple families tell me they go back to speaking Italian or German or Vietnamese, and their English kind of gets erased, and they go back to that native tongue. We also hear a lot of cuss words coming out, and I have families ask me, where did this come from? My mom never cursed a day in her life. And all of a sudden you hear some of those awful, awful words, and kind of the hate language, I call it sometimes. And where is it coming from? It's been maybe buried deep down inside their brain, and it's bubbling up to come and speak. They do end up speaking less, and sometimes people with memory loss do become mute, or they grab into a phrase and repeat that same phrase over and over and over again. It's really hard not to argue with someone, but arguing with somebody who has memory loss is not going to help at all. The situation is just going to intensify it. So we want to use don't argue, and use very short, simple sentences. No quizzing allowed. If somebody remembered that they just had lunch, by quizzing them over and over again and saying, well, didn't you remember we just had that hamburger? it's not going to help the situation. And again, we're not correcting or fussing them and asking them to remember. One thing that we find that's very helpful is when you're dealing with somebody with memory loss is also use your body to help them understand what you're talking about. Let them look at your face, let them look at your mouth. And when you're trying to get them to come somewhere, simple things like come on or let's go sit down, and even going to them, it's time to go to sleep. Using our bodies as a form of communication really is helpful because it's an extra thing that that somebody with memory loss can look at to try and get into their brain what you're saying to them. Okay, we have to rephrase a lot and say things different ways to maybe help get our point across. But instead of saying, don't do that, you shouldn't do that, say instead things like, let's do as much as you can, and then I'm going to help you, or I'm here to help you. And the more you try and rescue that person who's needing help, you'll see they're more open to let you come in and help them. Again, when you're caregiving, you're entering that very, very private space. They know they need help, but they're afraid to ask for it, or maybe they're too strong and they don't want to ask for it from you. But the way you approach that and approach them and know that you're friendly and you're their friend and you do want to help, they're more open. So just kind of giving you some tips about meal times around the house, because meal times and eating is so, so important. We have to really have a soothing environment and calm environment when we're getting ready to eat. It helps preserve their dignity by showing them that you're compassionate and that you really care about what is going on at that moment. If you're trying to help somebody eat their dinner and you're running off back and forth to the kitchen, you're not sitting down with them, they're not going to eat. Sometimes they need jump starting, so they need you to have your focus, your attention on them. And that's what's going to help create that soothing and calming environment and that dignified environment for their mealtime. It's really hard to stay on a routine with busy families and busy lives, but routine is so, so important, especially when it comes to mealtime and getting the right hydration in for the day. So routine meal times, limit your distractions, keep things very simple. When we were raising our kids, we would check that hot soup to make sure it wasn't too hot to let them take a bite. We do the same thing with somebody who's either has advanced help, needs advanced help in eating, to make sure that they don't burn themselves. You have to give them time to eat. There's no rushing here. The more you rush, the more you make that environment hostile almost, and they don't want anything to do with being overwhelmed or getting too anxious or too much excitement going on, and they will just kind of shut down. And it does get messy, but the more you let them do for themselves, that's more dignified. Things do get messy when somebody feeds themselves, especially if it's like spaghetti and meatballs or soup or something like that. But you can always clean up the mess afterwards. You can always wipe off the hands, you can always wipe off the face, you can clean the floor and the table. So the best thing is to try and let them feed themselves first and intervene and kind of be there as a coach or to help cue them. Some of the best things to feed somebody who's having problems with holding a spoon or a fork is finger foods, and food preferences do change. So it's not, as months go by with disease process, maybe what they always liked cereal with milk, maybe they don't like that anymore. It's too hard to eat, so they'd rather have something else. So neatness does not count anymore. Again, as I was saying, this is kind of a messy and indignant process for them. So we want to make sure that we are allowing them to do for themselves as much as they can do. The more they do for themselves, the more self-esteem they have, the happier they'll be. Okay. So again, flavor is very important to them. I have all kinds of tricks for helping people get that flavor added to food to make it palatable and to make them want to eat it. And my motto has been too, why not dessert first? That sweetness in the cake or that coldness in the ice cream really does help that appetite and help stimulate those taste buds in the mouth so that they can, at that point, they might want to go ahead and start eating some other more healthy food. Activities around the house, dental hygiene. I get asked questions a lot about the dentures because a lot of people do get embarrassed when they don't have good teeth, or they lose their dentures, or their dentures aren't fitting in anymore. And that happens with advanced age. It's just going to happen. The dentures are going to come out. The gums do shrink. They do take their dentures out, hide them in napkins. I have found dentures in the back of toilets because somebody wanted to wash out their dentures and clean them out. So we have to figure out, if the dentures aren't fitting it anymore, maybe they're uncomfortable. If they're getting loose, is it really a dignity issue? Are they needed anymore? So those are kind of things to think about when you start having issues with not being able to find their dentures, or not being able to get them out of their mouth anymore to clean them properly, or if they're starting to get really loose fitting. Bathing is one of the hardest, I think, personal care issues, and that I run into with families. It's very hard to get into somebody's personal space, and a lot goes on with bathing. So some things that you want to do when it comes time to help somebody shower. I don't say that anymore. I don't use the words, we're going to go take a bath or we're going to take a shower. I cue on to some other things that make them feel good. I had a lady one time who loved to do laundry. And so to get her in the shower, we would just say, it's time to do laundry. And she would go right with us. So that was her cue and her time to, or her trigger word to go ahead and cooperate and go take a shower. But always prepare your space first, prepare the bathroom. Have things like tearless shampoo, a handheld shower, grab rails for safety. Shower chairs are great. You want to get a nice sturdy one, and Prachi can tell you about some of those. Non-skid flooring, towels on the floor. I use a lot of towels at bath time because people don't like to feel that cold tile on their feet. So just by putting towels down, and they feel more secure. They feel like they're not going to slip. So they're more able to go with you. You can buy heat lamps very inexpensively. Older folks get very cold, or people with thin blood, they get very cold, and that heating element will really kind of make them feel warm and cozy and want to get into the shower. They make music boxes now, or little radios you can put in your shower. Music is one of those things that you can use that creates a nice environment. It can create joy. It can lift somebody's spirit. It can just totally change what's going on in the environment by putting on somebody's favorite music. So we use music a lot to kind of create a therapeutic environment, but to put on a happy mood. Mirrors too can be very frightening to somebody with dementia. They can think that somebody is watching them, or they can look in the mirror at themselves and not know who they're seeing. So that's kind of a scary situation if you're looking right at somebody and talking to them, and maybe they're not answering back, or you're just not sure who that is. So I suggest taking mirrors down, especially in bathrooms, because they don't want to undress in front of somebody else. So, and there's ways that you can undress somebody and help somebody get undressed that keeps their dignity and keeps them covered up, just by leaving on that t-shirt when they're getting into the shower, or keeping that towel wrapped around them. Okay. Bathing is a good time to kind of check around for some skin tears. As we get older, our balance is off, and they do bump into walls and scrape their arms on just scooting up to a table and things like that. When we buy new sneakers, sometimes you get blisters on the back of your ankles. This is a good time when you're bathing to kind of check those things out to make sure they're not needing any extra attention around the ankles and the feet, and elbows too are a big spot. Skin care, they get very dry skin, and you want to kind of help them out with that. Again, somebody with advanced disease process, or with advanced Alzheimer's or dementia, they don't know to care for their bodies either. They're not going to tell you, hey, I hurt somewhere, can you look at this? We have to kind of be proactive and intervene to help them a lot. Look at lowering your water temperature so they don't get scalded. And again, just like eating something hot, you want to make sure that you're filling the water before they do. I have told many family members, to get into the shower with them, why don't you just put on a bathing suit? So that can be very helpful. So that way you're even closer to them for that personal contact when you're having to do some wash, but not expose yourself. So here is something too that is very messy in caregiving. A lot of times there is a let go of bowel and bladder when they're in the shower, on the shower chair. So I would suggest getting some of those throwaway pads or even an adult brief and putting it underneath that shower chair, putting it on the shower floor so that when they are showering, if they do let go, you've got that protection there for all of you. Dressing, again, we want to always maintain dignity and maintain their appearance. We want to make simple choices and simple outfits, anything that can help them dress themselves. Snaps or pullovers are good items for them, good clothing items, and easy to remove and easy to put on. Sometimes we have to use the watch me technique to help someone get dressed. You kind of get dressed with them and they're watching you, just like when they're brushing their teeth, they're watching you to go through that process. So here's some ideas to think about preserving dignity. If you're physically having to dress someone, do we need to check out the bra that the female is wearing? Do they really need it anymore? Can we just put a t-shirt on, or do we need to adjust the style of the bra? Had many conversations with husbands and daughters, even talking to them about the undergarments. And pantyhose are really kind of going by the wayside, but I always have a funny story from way back in my early days. I had a husband who approached me and he was helping his wife physically get dressed, and he couldn't figure out why he kept getting slapped every morning. So we started talking about it, and I said, well, tell me what you're getting, her dressed. And she would wear slacks, but he would put on pantyhose, full pantyhose underneath the slacks and then put the slacks on. And she was getting really upset with him. And so she did start slapping him. And I said, oh my goodness, pantyhose, that's a lot of struggling. And he goes, yes, it's been a big, big struggle. I said, don't do it anymore. Go up to Walmart or Target, go buy some little white socks, put on with her sneakers, and I bet you she won't slap you anymore. And that worked. So it made everybody happy. So we just kind of have to think about what is important at the moment. Are they better off with pull-on pants, little socks instead of pantyhose, snap closed dresses? I really like the new invention of the Velcro shoes instead of ties. The shoelace is something that somebody with dementia loves to untie, knot, tie back up, and then they can trip and fall and get hurt. So I really ask families to look at getting some Velcro shoes. On top of that, if they're walkers and they're constantly walking around, this will help when their feet start swelling and ankles start swelling, because the Velcro shoes expand a little bit easier and better. Okay, and we always want to check for the right fit too. With the aging process and even with dementia, especially with dementia, they do lose weight quickly. And so we want to keep making sure that their pants aren't going to fall off and, those aren't getting too big for them. Now this is, incontinence is also a subject that's kind of hard to talk about. Incontinence is going to happen with somebody with dementia. It's part of the disease process, but it can happen with anybody in a normal aging process. They can get bladder leaks from prolapsed bladders and from other medical issues. Diabetes and medications can cause incontinence problems, but with the dementia, they're definitely going to need some help along the way to help them go to the toilet every 2 hours, to help them get personal hygiene. And something that's very common with them is a urinary tract infection. Sometimes as a disease process advances with an Alzheimer's patient, they are getting urinary tract infections like almost monthly or every 5 to 6 weeks. And they're hard to prevent. Antibiotics work for a while, but it has a lot to do with like the cleanliness, and it also has to do with just the fact that they're not voiding all the way. So we want to look at urinary tract infections and keep our eyes open for some of those symptoms like fever or vomiting or going to the bathroom too much or even not going enough. Just when you see the change in that, the going to the bathroom, that you want to kind of look at to see and investigate a little bit more to see if there's something going on. So also just looking at how far is the bathroom from where the person is. If they're starting to have accidents, is it the environment that's creating the problem? Are they getting too, are their clothes too hard to get off? Is the clothing an obstacle? Again, sometimes it could just be the disease. Okay, next. Here's some guidance about preserving their dignity. If you can limit accidents by intervening in prevention, that's definitely going to help. We want to be supportive. It can be very embarrassing and awkward if they have an accident, and sometimes they don't even realize they've had that accident. They'll look at the wet spot underneath them and go, "What is that? Who spilled water on me?" So those kind of things will happen, and also with bowel movements. So there's a variety of products on the market. I'm going to show you a couple of them in a little bit. And find out and learn what somebody's trigger word is to go to the bathroom. When we were raising kids and getting them toilet trained, we would say certain things to get them cued to go to the bathroom. Well, same thing, it can be almost anything. I've had some seamen that, Navy men that would say that they had to go to the head. So I had to tell my staff, well, the head means going to the bathroom. Or some very proper ladies might say, I have to go to the loo. And again, that meant got to go to the bathroom. So some women, again, there's like 100 ways you can say you have to go to the bathroom. You don't have to go TT. That's another one to look at. You can see them start pulling on their clothes and not being able to tell you or holding their stomach. And again, they're not going to tell you, I've got to go to the bathroom, but those are some cues to you as a caregiver and their trigger words to figure out, oh, I think we need to go to that bathroom. Again, doing a routine every 2 hours really is going to help keep that incontinence in check, and really making sure that they are clean and giving them personal hygiene, making sure that's in check is going to help those infections. Next slide. Bowel movements really need to be tracked. As somebody starts getting through the aging process, advanced age too, they do talk a lot about their bowel movements, and too with dementia patients. Constipation is not a pleasant thing to happen. It is created by dehydration or sometimes pain medications, sometimes just a disease process because they're not able to know when they have to go properly and they don't push. So sometimes you have to look at giving them some medication like Miralax or something else to help them go to the bathroom, because that can be dangerous if they get constipated. It can cause some more infections, but then it also is really a mess when they do get constipated. This is where we go and talk about the reality is they do stick their hands down their pants and they will take the bowel movement out. And sometimes they get to smearing it or ingesting it. If you ever suspect that somebody has ingested feces, make sure and call your doctor immediately. And also they'll blame other people for that because again, they're in their world where they don't know what's going on, and they kind of look at it and go, I didn't do that, you did that. So we want to prevent this by intervention and trying to do the toileting every couple of hours and keep their dignity in check by helping them with that prevention and intervention. Okay. I love Balmex. You can get this anywhere, any of the drugstores, Walmart, Target, but it really is a skin protection. It's a barrier cream, and it has a lot of other helpful things that it can prevent future wound problems. So I've used it on scratches. I've used it on like bruises to help cover that bruise so it doesn't open up and become more of a wound. It does help with jock itch. And sometimes if people just kind of have itchy, dry skin, and sometimes somebody with dementia gets that kind of OCD, and if they feel something on their skin and they constantly are picking or itching it, you put a little bit of the swell mix and it kind of protects that skin there, and they have a different feel now, and they're not as apt to keep picking at it. So I highly recommend keeping some ball mix around, especially when somebody becomes fully incontinent. You want to put that barrier cream on their bottom so that when they do get wet, it's going to protect the skin from breakdown and more problems. Okay. And the next slide is some pictures of some briefs. The one on the right is a full brief with the tabs on it. And these can be bought at any drugstore, Walmart, Target, Amazon, any place. But the one on the left side is like a pull-up brief. It's like underwear, and they make them in all different colors now. So people of all ages having any kind of bladder leaks are wearing the ones on the left that you can buy. And somebody who's fully incontinent, who doesn't know or cannot go on the toilet anymore, and has to use a brief for that, you would use the one on the right with the tabs on it. Okay. But accidents will happen, and the important thing is to kind of do check and figure out, why are they happening? Is this a trend, or did it just happen suddenly? Again, if it's a sudden change in any kind of behavior, you want to make sure that you are clean, checking it out to make sure that it's not an infection or something that needs to be looked at by the doctor. But you want to clean it up immediately and look at getting some of the products. I always keep like peroxide on hand with a little bit of water. That's a good odor removal chemical, and it doesn't stain anything, but it does help clean, and it's a sanitizer as well. But anything, you can go on the market or into the stores now and see all kinds of things on the market for helping clean up pet odor, which works for humans too. And also there is other things for humans for taking out pet or taking out the odor. But again, intervention's the key, and reminders to go every 2 hours. And you want to make it easy for them to get their clothes off so they don't have those accidents. Early intervention, working with anybody who, and this pretty much goes with anybody with getting some kind of advanced disease, and working with dementia patients. Supervision is important, and there's a way that you can supervise somebody and let them keep their dignity, and by intervention and kind of being there as a helpful hand for them. It's very frustrating being a caregiver, but it's also frustrating for the person with the forgetfulness and the memory loss, because a lot of times they know something's going on and something's wrong, but they're not quite sure what it is. Their independence is compromised, but we have to watch for their safety. So it's very hard to intervene on somebody who seems to be fine and normal, but they could not tell the police what their name and phone number is if they got lost on the street. So we always are thinking about safety first with them. And a lot of times somebody doesn't know that they're really ill, and they deny that they're ill, and they don't want help from us. But we have, as the caregivers, we're always trying to make sure that we're securing their safety, and while we're preserving their dignity at the same time. So it's two-way. And looking at some late stage care and monitoring somebody's well-being, that also helps preserve their dignity. So disease process can, depending on what's going on, can last several days, weeks, or to years. Preserves, anytime we can preserve their quality of life by caring for their spirit and caring for the body, again, that's going to create that, it's going to create that quality of life and help them transition and just make everybody happier. We want to keep their skin and body healthy. We want to prevent any kind of pressure sores. Again, if somebody is late stage, they're usually bedbound, or they're bound to maybe a wheelchair. So you want to make sure that you're doing some kind of range of motion and helping them move their body if they can no longer move it themselves. Do exercises with them, pick up their legs, roll their arms around, move their wrist and their fingers, get a beach ball and toss it to them. That creates that range of motion and again, that exercise. I always recommend having lots of pillows around too. As we get old in general, we get all kinds of aches and pains, but different parts of our bodies do end up being compromised from pressure. So you want to kind of protect them by maybe placing pillows underneath arms or underneath legs, especially if they're in bed bound. Dehydration is a fact of not drinking enough, and somebody with late stage, any kind of disease process or late stage dementia just does not want to drink, and it's hard to get them to drink any kind of fluids. So I suggest things like Propel or lots of Gatorade. I'm really a proponent for Gatorade. It has electrolytes in it and kind of has that sweet and salty taste. And if they can stand the sodium, keep that around because that will rehydrate somebody rather quickly and keep them going. Swallowing problems do develop later on in the disease process. You'll notice a little bit of choking at first. And you can the person can be evaluated to see if they are swallowing properly. And it might just be something as simple, let's first slow down on the big chunks of meat and make things more shredded. And then to a point where they might need actually pureed food and thickener added to fluids. So that will help them be able to eat. But with later stage, they are losing a lot of weight and not eating enough food to sustain, and you are going to see them kind of waste a little bit. The weight can come off really quickly. Somebody can lose 10 pounds in a week, and you're looking and going, well, wait a minute, she's eating all the time. Why is she losing all this weight? They have a lot of nervous energy that they burn up constantly, especially if they've been walking around. They can burn up a lot of calories quickly. Okay. So as I said, the swallowing difficulty period and monitoring their weight. And next slide. I know I'm getting long on my time. So we want to know when it's kind of time to let go. And I tell people when they're starting to have trouble eating or drinking, it's time to look at, again, to be evaluated. And the choice to allow natural progression is something that the family needs to discuss. The disease is going to compromise their ability to eat and drink and have nutrition. So a feeding tube is not something that's going to make them better, because this is part of the process of dementia and Alzheimer's disease. There are times when feeding tubes are appropriate, but when you're dealing with somebody who has a progressive disease like this, then things you should know about that they're not going to get hungry or thirst as they approach death. They don't feel that. The lack of food and fluids may reduce their pain, actually. And a feeding tube really won't prevent their weight loss. And the feeding tube or even giving them IV might really be more uncomfortable for them, because this is an actual disease process. So it might be more uncomfortable and more painful for them to go through with forcing the fluids and the nutrition on them. So some things I always suggest people to do is do journaling. That helps you look at the path that your loved one is on, and it helps you focus on what you need to tell the doctor and need to tell other family members, because family members always want to know what's going on. Okay. So things to look at too, just when in our everyday lives, I tell people, halt. When you're not feeling right and your mood's changing, find out, are you hungry or angry or lonely or tired? And we all get that new word I hear is hangry. So if your mood is changing and you're feeling extremely tired, look at your day, stop, halt, and find out if you really need to drink some more fluids, or you need to eat something, or you need to go rest for a little bit. Next. So we're trying to figure out the causes of the behavior change. So I ask people to go back and look at your journal if you have to. Examine the episode explore solutions, and try different responses if needed. You have to be sometimes a good detective, and a caregiver sometimes has to be very creative of how they get their information too as well. But you want, anytime you see any kind of behavior changes, try and figure out what's going on. Okay. I think we might need to skip through a little bit, Candace. I think I'm a little long here, but there's different examples.
Jamie.
Okay. So different types of behaviors that we see in Alzheimer's patients. Sundowning really is something that you could almost set your clock by. Their behavior changes, they get more anxious or more fidgety, or they get that syndrome of they're more tired, or you just notice at a certain time of day, and it's usually between 3 and 4 or 2 and 4, you notice a different type of behavior. And they start asking things like, or telling you things, I've got to go. My son's waiting on dinner. I have to go to work. I have to go home. So this time of day is not a good time for you to choose to try and give somebody a shower, or even to take somebody to a doctor's appointment later on in the day, because that's kind of a bad time for them. They've already been through a big chunk of their day, so they're getting more tired and kind of confused, and that sun is going down a little bit, and it's creating some behavior changes for them. And you do see some aggressive behavior with sundowning individuals too. And just to mention, not all Alzheimer's patients can be aggressive. That's like not the norm, and sometimes people think it is. It's aggressive behavior can usually be related to something going on with them, either medical issues happening, or they're very confused about what their caregiver is trying to tell them to do, or it's just the disease. They're just so frustrated. So we look at aggressive behavior as trying to figure out what is the root of it, and see if we can kind of intervene and stop that. Okay, next one. Other behaviors, and it's not just for Alzheimer's patients, but these are warning signs that there's maybe a medical problem happening. Hallucinations, seeing things that aren't there, or thinking people have called on the phone that haven't. Repetition with the way they're talking, repetitive vocabulary, or repetition in doing the same act over and over again. Sometimes constant folding and hoarding papers, and the constant crying. And you don't know between constant crying and humming that gets accelerated, or sleeping too much, if that's some kind of medical problem happening. It could be an infection, urinary tract infection happening. It could be the fact their medication is wrong. It could be a lot of things that are going on that need to be looked at by a physician. Behavior intervention. So when you see somebody's behaviors change, you got to think, do I need to intervene so they're safe? So that's something to always think about first. And you can distract them most of the time to change that behavior. And sometimes if it's just a disease, it's just you have to wait it out till that switch goes on and off again. You want to change direction of the conversation. And sometimes just walking out of the environment that they're in changes that behavior. So remember that too. And medications too can be an intervention, but there's different types of medications you have to be very careful with as well when medications are being used. So also another acronym other than HALT to take away is TALK. So when you're caregiving with somebody, you have to take it slow. We don't want to rush. You want to talk slow too. And help them understand and be patient so that they can try and process what you're saying. A is for ask simple questions. Ask them what's going on. See if you can figure out what's in their head. And limit their reality checks. You want to limit arguing with them, because that's not going to help anybody. And keep eye contact. I know it's been hard with the masks over the last year and a half, and even working with a lot of my families, it's been hard with having your face covered, because then somebody with dementia too, and even normal people, it was hard to hear what you were saying, but it was also hard to process because you couldn't see the lips move and you couldn't hear them very well as well. So remember, take it slow, ask simple questions, limit arguing with them or the reality checks, and keep eye contact. So that's a good intervention. Safety is a big concern. Now, 60% of Alzheimer's patients do wander Are they wandering to look for where their home is? They're wandering because they see a pretty red truck out in the parking lot they want to go look at, or they're just looking for something to do. So there's some different types of things that are available. The Medic Alert Safe Return Bracelet is available at the Alzheimer's website, alz.org. And also there's a scent kit that the Department of Elder Affairs has, so you can actually protect the scent of your loved one. So if they do wander off, you can give this nice little box scent kit to the police so that they can actually try and track down your loved one. But look at safety proofing your house. There's different locks to make sure they can't just easily open them. Sometimes you have to just simply turn off a circuit breaker to your stove so they don't go and catch the house on fire. Don't ever leave them alone. And use child-proof locks for drawers and closets and cabinets. Hide your car keys. Make sure that you have a set accessible to you in case your loved one takes the car keys. And also have a key. I've had many of family members locked out of the house, so I tell them either hang the key around your neck or hide one outside so you can get back in your house. There's some magnets you can buy at Target or Walmart and put your key in the magnet and put it on the back of your AC unit outside. So that way you always have a key to get into the house. Alarming the house can be expensive, but there's also inexpensive little alarms you can buy now. Again, I love Walmart, Target, Amazon, Home Depot. Any of those places have little small ones you can just add on to a door if you're afraid someone's going to walk out the door and you can hear them throughout the house. Okay, next. But safety first is my motto. You have to watch out for them. And again, the more you keep them safe, it becomes less of it is more preserving their dignity if you keep them safe. So driving, if somebody's still driving, again, you want to get them evaluated. Anybody with any kind of advanced disease to diabetes or some other items, you might want to get them, some of the diseases, you might want to get them evaluated every 6 months. It's hard to take the keys away, but it's tough love time. It's either taking the keys away or having somebody's life in jeopardy and in danger. I had to disable my mom's car because I didn't know what to do with it 30 years ago. So we disabled the car, and that might be your first step, or let it run out of gas. And a question to ask if you're really contemplating whether or not to take those keys away, would you feel safe in the car with them driving, or would you let a 5-year-old in the car with them driving by themselves? So that's another question I give to families. Okay. So some survival tips for us as caregivers. Please stay healthy. Don't forget about your own health, your doctor's appointments, checking your blood sugar, blood pressure, making sure you're staying hydrated. And a lot of families I'm running into really don't have that backup plan. Make sure you have a backup plan in case something happens to you. Take one day at a time. There's always tomorrow to get something else done. Tomorrow's a new day. And keep your sense of humor. Humor will get you through. Humor and music will get you through this caregiving experience. Get enough rest at night and make sure you're eating right. And, to keep a positive note on what your loved one is able to do, keep a list of what they can still do. Focus on what they can still do, not what they've lost and are unable to do anymore. But there's a lot, if you're creative enough, there's a lot of small things that you can enjoy together that mean a lot, and be flexible as a caregiver. Give yourself credit, not guilt. Don't feel guilty about it. You're doing the best you can. Things come up every day, and it's going to be messy caregiving at times. It really will be. It's no fun to get into somebody's personal and private space and have them almost attack you because you're trying to help them. But know down deep inside that they do love you and you're doing the best you can and you're loving them right back. And all the information I've provided has been from years and years of experience and working with the Alzheimer's Association with patients and families and with Department of Elder Affairs. And the last slide is I have a book available, actually kind of a journal and a couple journals and a book, and it's also available on my website to kind of help you along as a caregiver. And I hope you ask those questions if I didn't cover something. I know it was a real quick overview.
Thank you, Katie. I know we went a little bit over your time, but it was so much great information that I really wanted, the opportunity to share. But if you do have any questions, if you need any clarification, if you want any recommendations on any interventions that you're trying, or you just don't even know where to start, you're welcome to put those into the chat and we will address those once we get to the expert panel. I'll make sure to read all those questions out loud. And also just a reminder, I see something in the chat. We are going to be sharing the recording. I will probably send it out by next Tuesday or Wednesday, along with a PDF of these PowerPoint slides and any additional handouts or resources that any of our presenters share today. So I want to move on to the next topic. And Robert, I know we're a little bit into your time, so if you need to take a couple extra minutes, that's totally fine. But I want to introduce Robert Bossarge. He is a psychiatric nurse who has treated clients and taught and consulted with many of the nation's top hospitals. And right now he currently supervises the behavioral health program and treats psychiatric patients in the home and teaches clinicians all for concierge home care. So thank you so much for being with us today, Robert. I'm going to go ahead and turn this over to you.
Great. Thank you so much, Candace. And thank you all for joining us. I believe education and talking and dealing with our emotions about all the difficulties are the only way we're ever going to get through any challenges. And certainly caring for patients with dementia and their families is such a physical challenge, a mental challenge, and a spiritual one. So I'm just appreciative that there is this platform in Jacksonville, and I'm happy to be a part of it. So speaking of, challenges, sex is often a difficult thing for anyone to discuss, and it certainly becomes a little awkward or uncomfortable, even shocking when we're talking about our own loved ones that may be behaving in a manner that we're not accustomed to. So today's talk hopefully will help explain what hypersexuality is, and then, the primary focus to let us look at what strategies we have. So on we go. Again, I do work for Concierge Home Care, and I love that our motto is caring for people who care for people. We really do try to do that, and just one more reason why we're happy to be together. So kind of our specific goals for today, very simple. Like we said, we'll look at what hypersexuality is. There's actually not a very good clinical definition, but I'll try to make what we call an operational definition, just a term that we can all agree upon, that if you sense it, if you feel it, this is probably it, and then what can we do about it? And the primary focus will be looking at that treatment overview. There are medications that we'll look at. We'll really focus on interventions, and then you as the caregiver and the environment as one of the primary interventions, very similar to a lot of the topics that Jamie just spoke so well on earlier. We'll kind of dig in a little deeper as it kind of applies to this disinhibition or inappropriate sexual behavior. And for me, for everyone, when we're looking at dementia care, it's always how do we help the caregiver? So we'll look at coping for you all as well. So it is also hypersexuality, known as ISB in the clinical terms, which simply stands for inappropriate sexual behavior. For me, that's a poor definition, because how do we know it's inappropriate or not, right? You probably are a very good judge in your own home, you caregivers. So keep that in mind. It is also known as disinhibition. Part of that definition I actually do like, and that's because sex is actually normal. We are all mammals after all. So what prevents us from behaving, quote, inappropriately in public? Well, we have inhibitors that stop us from behaving that way. And what can happen with dementia patients and with other neurological conditions, psychiatric conditions, is that our little governor, our little control switch can be impaired, and boom, we are disinhibited. So we'll look more closely at that. Again, for a kind of a more global definition, we could just say that hypersexuality, or this inappropriate sexual behavior, could involve verbalizations, it could involve certain actions from the patient, or even their own focus on areas of the body or actions or terms that are generally considered sexual in nature and therefore might be inappropriate in a given situation. Some examples could be inappropriate welcoming, a very long hug, maybe an inappropriate hug at a wrong time, maybe inappropriate touching. There could be unwanted flirtation, which could be very innocent at first, and it could develop into very concrete and clear sexual talk that may not be appropriate. Sexual talk with a relative, a child, with a caregiver. Could involve changes in normal sexual behaviors. Many older Americans are still very sexual. That's a common misperception that if we hit, I don't know, 50, 60, that we no longer have sex drives. That's not true. The statistics, when they do examine it, is that most older adults are still sexually active in some healthy way. And so what we might see in a person with dementia as the disease progresses is that the normal sexual behavior that that person exhibits could change and likely will change. It could be an increased frequency in overtures or about sexual talk. It could be an increased sex drive, and it could go through kind of a spectrum all the way through aggression, unfortunately, in its most extreme. Some of the most uncomfortable aspects for clients that I see and for family members is when the person with dementia fondles themselves in public, or maybe actually strips, takes off their clothing in public, or goes the full length to then masturbating in public. So those could be some of the more extreme behaviors that we might see that obviously could make for a very shocking day for people and very difficult, challenging moments. And that's what I'm hoping to hopefully help resolve for you all today. Just, we might be asking, why is this happening and how often does this happen? So it is not a common thing that happens in all of persons with dementia, but it's about 7 to 25%, depending on the studies that you look at. Unfortunately, even though this is such a challenging area for caregivers, there are not a lot of large, well-designed clinical studies on this. There are more and more as we go on. They're usually very small, but when we put the data together, I would say 7 to 10% in all patients with dementia. Those higher numbers, 15 to 25%, are with patients that have frontotemporal dementia. So if you look at the diagram below, at the front of the brain, where the front of our brain, which is the frontal lobe, meets the side of our brain, which is the temporal lobe, right in this area of our brains, it seems to be where we have a lot of those governors in place that we talked about, things that would normally help us with our inhibiting of inappropriate behavior. When those areas are affected with the dementia, we see a dramatic rise in the prevalence of hypersexuality. The pictures below are just kind of letting you see that what can happen as the disease progresses to the brain overall is that the gray matter, the actual tissue of our brain, does shrink. And I like for us to see this because sometimes it's a nice reminder when we ask, why are they doing this? Why are they saying this? Why is my intervention not working? We kind of beat ourselves up. This is why, right? The brain tissue is actually shrinking, and it is sad and frustrating, but it can be a helpful reminder to us that this is what we're dealing with. And if an intervention is failing, it's not because you're doing anything wrong. It's also not because the person with dementia is willfully testing you either. On the next slide, you'll see a different version of a brain with Alzheimer's, just to let you see a real brain more globally versus just the CAT scan there. So you can see the marked loss of gray matter there, marked atrophy. The brain actually does shrink. And so as we move forward, we can look at other factors that can make hypersexuality worse, or really any behaviors that are challenging within the realm of caring for people with dementia. As the cognitive functioning declines or worsens, we may see that hypersexuality worsens as well. We do see in the numbers that for persons with dementia that reside at home versus that are residents of an assisted living facility, for example, nursing facility, the numbers are much higher in a facility. The presence of any other disorders can also impact hypersexuality and seem to make it worse. Parkinson's disease is one specific example. Also multiple sclerosis. Scientists aren't sure why, but we know with both of those disorders, those are affecting other neurotransmitters and other functioning of our brain. So it could be likely to affect those same areas of control and disinhibition in a person with Alzheimer's. Any other brain injury, whether from a fall, a car accident, or a stroke, can also do this. And of course, any other psychiatric disorders that the person with dementia may have had prior to their cognitive decline, and also addiction disorders in general. Could be all things that make hypersexuality a little bit worse. So you'd want to make sure that if we're seeing this and you're looking at how to address it, that with the primary care physician or with the gerontologist or neurologist, that we're looking at all of these other factors. So if there are other conditions that are treatable, we'd want to definitely treat them too, in the hopes of alleviating any of the symptoms of hypersexuality. I mentioned this earlier, but obviously if our loved one is exhibiting any of these behaviors, it can cause a lot of anxiety, a lot of distress and embarrassment for either the spouse, the children, even for caregivers themselves in the professional sense, doctors, nurses, aides at facilities. It can just be an awkward and very challenging environment for all of us. And for some, it can actually be very traumatizing, both mentally and physically. On a mental level, for a daughter to maybe witness her father do this, or for a wife to maybe see these changes if a husband becomes aggressive, or maybe the husband is flirting with other women, maybe he's forgotten that he's married, can be very traumatizing mentally. It can go to the physical, of course, if it leads to any type of assaultive behavior, but also for some people, if they end up into a situation where they are masturbating a little too much, they can do a little physical damage to their organs as well. So this is all part of why we really are happy to be talking about this with you all today, and happy to hopefully be providing solutions, because we don't want all of this suffering really on everyone's parts. From a point of view of clinicians, and also maybe if you're the power of attorney, and also if someone is in a facility, it can cause a lot of disruption and conflict in these areas, including staffing issues, and there can also be legal and ethical considerations. I like to just make a quick note on this, because sometimes when patients are in a facility, residents, they may develop a relationship with someone else. That is not necessarily wrong. And their romantic inclination and also sexual inclination is not necessarily wrong or inappropriate either. All of these are judgment calls, but I just want to remind all caregivers that we want to be aware of the patient's autonomy and the person with dementia's normal sexual desires and romantic desires, and because I have seen in certain situations, certain facilities where they may not allow for two residents of the facility to begin a romance. So again, it would take good assessment and a team effort to make sure to do both these individuals have the ability to give consent, and does this relationship seem to be healthy? Then I don't think that we can really stop that. So on the next slide, as we move forward, we'll be looking at what we can do. And this is really where I want to dig in with all of you guys. So like I said earlier, when we're looking at what we can do, just always keep in mind that sex is normal. And if our loved one is engaging in what we might consider inappropriate sexual behavior, the answer, very similar to what Jamie mentioned earlier with a lot of our solutions, is never to use shame or blame. Those can be toxic to the individual, and we really shouldn't use them to control behaviors. We always want to help a patient, a loved one, be able to maintain their dignity no matter what's going on. And that does put a little bit more onus on us, which is emotionally challenging. I just want to make sure that we're always very careful, particularly in this area of sex and sexuality. And again, just to remind us, tying in on what we just spoke about with the facilities, all persons, whether a patient, whether a resident at a facility, have constitutionally guaranteed rights to maintain both their autonomy and their dignity. So when we look of what for interventions on how we can help, we want to keep that in the backs of our minds. So the three areas that we might look at, obviously the patient themselves, right? So when we're thinking, what can we do? So with a patient that has dementia and is exhibiting these behaviors, the two primary methods that modern Western medicine would look at is, of course, medications, and there are a number that are helpful that we'll look at in a few minutes. And then, of course, traditional cognitive behavioral therapy. This is where we might talk to them about what is going on. Hopefully, when we talk to them, we're also listening, and then we can develop a workable plan together. The next part of this, of course, is the caregiver. It's you guys. And I would say that this is almost the more important component. So we want to look at education for caregivers so they can develop strategies and also get support for just how stressful this is and for all of the other stressors in dealing with someone. The part that's often forgotten, or at least not given its own realm, is the environment. We probably, hopefully, if you've attended other workshops or training, we've looked at what we call the no-fail environment. So on the next slide, you'll see we just kind of put it all together that in order to treat this in a positive and productive way, we will look at dealing with the patient, we will look at the caregiver, and all of that, we need to look at the environment as well. So you'll notice that all of the interventions from the next slide on will really look at how do we handle all of that together so it's more effective for you. At Concierge Home Care, we do have a program called the Boats Memory Method, and it's actually available not just for concierge patients now. And it's really an innovative assessment and training and communication program developed by Sarah Boats. She's an occupational therapist. We look at combining functional assessment, individual planning, and training for the patients and the caregivers themselves, but also staff members at facilities. So we can help everyone, not just the client, but the caregivers and the families as well, to not just cope with dementia as it progresses, but also just thrive during this time. So this is an approach, and we're working together on a behavioral health model overall. So this is something that you might want to look at too for other sources as we move on. I think medications are going to be coming up next, and I'll just be brief on them, and I can answer more questions later if you all want. The medications that have a demonstrated effect, there's a lot of, as we're all aware, on the internet and in modern society, there are a lot of scams. I always want to caution everyone when you're looking on the internet or at a magazine and you see something that says it's going to fix everything, keep in mind, number one, if they promise you the world, it's probably not real, but always check. You can always ask your provider. You can always ask a clinician. And if you yourself are comfortable on Google or any other web engine for searching, you can search to try to find out. I would just encourage that we look at reputable sources. So I usually encourage people to go to Alzheimer's organization, to go to mayoclinic.org if you're looking at medical questions. And any extension that ends in .edu is usually a university or a college. So those would be good sources for information, as well as the extension .gov. So we would be looking at, say, for example, the National Institutes of Health or the National Institute on Aging within the NIH. You want to make sure you're getting accurate, factual information. You're not using something that's not going to help. The medications that do show some promise, psychotropics, those would be the medications we use for depression, for possibly mania or psychosis. So some of those medications, the antidepressants, the antipsychotics, and what we call anxiolytics, those are medications to help with anxiety. They can help. The issue with these in the older adults is sometimes these medications come with more side effects, and those do tend to get a little worse with older adults. Also, with some of the anxiolytics, the anxiety medications, they tend to be disinhibiting on their own. So if we have someone with inappropriate sexual behavior and disinhibition, we probably don't want to give them a medication that will disinhibit them even more. In all honesty, in this department, just as a personal / professional recommendation, being a psychiatric nurse for 29 years, some of the last generation of antipsychotics are probably the ones that will work the best. And we're looking at, say, quetiapine or Seroquel or maybe Abilify, and probably in a lower dose. Anticonvulsants are also used. Those are basically medications for epilepsy. We have noticed that they do help with bipolar disorder and mood swings and mania. So many physicians will prescribe them for hypersexuality. The efficacy, meaning how well it works, is probably a little lower, and they can come with some unwanted side effects like sedation. So that probably would not be my first go-to personally and professionally. Now, there is a class of heart medications, or what we call cardiac medications, specifically ones that are known as beta blockers. There have been some large trials on this throughout the United Kingdom and Europe, and now finally in the United States. So some of the beta blockers, again, in a low dose, may help specifically for this disinhibition or inappropriate sexual behavior. And then there are medications in the final class, and these seem to be showing the most promise. These affect our hormones, like our sex hormones, for example. So there are hormonal medications, meaning these are hormones that we give, and sometimes we can use a hormonal medication to help. Or there are non-hormonal medications, meaning it's not a hormone, it was a medication designed to do something else, but it has an effect on our body's hormones inside. So these would be like cimetidine, ketoconazole, spironolactone. These medicines are used generally for other things, but interestingly, what we have seen is they are showing some promise in helping control some of the unwanted sexual behaviors that we've seen. That was about a 2-hour lecture in 2 minutes. So we're gonna move on. Hopefully that was clear, but at least it gives you a good basis if you're experiencing these issues with your loved one. You hopefully have a good conversation starter for your healthcare provider at the next visit. Now on the following slides, these are all things that we can do. Traditional cognitive behavioral interventions that we might talk about would be explaining any concerns you have regarding a behavior. I would say addressing it in the moment if it seems appropriate and the person's not agitated, discussing with them how it makes you feel, how it makes others feel. You may question them. As Jamie mentioned earlier, I'm always encouraging people to kind of take the temperature in the room. We don't want to over question the person with dementia too much because it may escalate them more, may agitate them. If we can, in that gentle, easy questioning, if we can get behind what is the person's own perception of this behavior, there are cases they may not mean it sexually. They may not understand or know that they're being sexual. Or in other cases, they may be aware that they're being sexual, but they may have misinterpreted you for their wife or for an old flame, and sometimes we go back in time. So if we can kind of be a little bit of a detective and help figure out what needs are they attempting to get met in this behavior, that can help us as we move forward to developing either preventive interventions or then how to intervene in the moment. Setting clear boundaries and limits. We might even create a written contract. Very often we use our written reminders for our loved ones with dementia. We use our calendars, right? Our real big calendars. Any of these that are already in use, we might have a written contract or reminder. And if Candace hits the next button, you'll see I have a reminder for you. All of this could be very limited in how well it works. And I'll be very honest with you. It really depends on the cognitive functioning of your loved one. As we move forward, sometimes cognitive behavioral interventions are not going to work. But as with all, it doesn't mean we throw them out. We keep trying. Sometimes we try one intervention, it works for a while, it doesn't seem to be working, so we shift to another. And again, this would be not just with hypersexuality, but with all of the management of the person with dementia. We don't ever give up. We just have a lot of tools in our toolbox and we're just ready. I always joke like we're a boxer kind of, right? So you're just ready to shift on your feet, put that old intervention away and try a new intervention. Keep in mind with these that what really help it to work are consistency and clarity. Try not to give mixed signals. That's very hard. Try not to ignore behaviors. That's also very hard. We think, oops, if I just ignore that, we won't have an argument today. And that's a judgment call on you. Sometimes of course, we will ignore. That's part of creating the no-fail environment. At other times, if we're dealing with a behavior that's particularly with hypersexuality, that's particularly stressful for you, the family member, or potentially dangerous to anyone, we don't want to ignore it. Then we want to try to be consistent. As we'll see on the next slide, we have a lot more tools in our belt that I think can help us more. And we'll start to dig in a little deeper. Some suggestions here would be real-time management, like we said. So if the behavior occurs, as best as you can, if you're choosing not to ignore it, go ahead and address it. Remember to stay calm and try to be patient. I always tell people, take a big breath before you say anything. Literally just go, try to check in with yourself, because the person with dementia, they respond much more to our facial cues, but as mammals, as all animals, we do respond to that energy between people. So if we're very anxious, if we're very angry, that energy is going to be contagious. So we want to make sure we're in check first before we do anything. Then we can gently but firmly ask the person not to do that. You may explain as above, the reason why is because it makes you uncomfortable, right? If it's taking our clothes off in the store, it might just be reminding them, we don't do that in the store. This may make other people uncomfortable. Remembering not to shame them, remembering to allow your body language and the tone of your voice to match the message, right? we talked earlier about those questions. So as you keep your caregiver journal and as time goes on, hopefully you'll be able to begin to identify some triggers. What is it? Is it shower time? Is it a nighttime? You know, what is triggering this? I'll share with you, my sister is a psychologist, PhD with the VA, and there's this older gentleman, always dresses very dapper, and he always kind of flirts with her on the way into her office. And this has gone on for a long time. And then one day he latched his arm under her arm and tried to escort her into his room to initiate sex. When my sister told me this story, I said, well, you know, if you had looked at some of these triggers earlier and you had looked at some of these behaviors, you might have been able to put that together, Elizabeth. His wife, who was deceased, looked very much like my sister, his wife when she was much younger. And during this time, it was coming up on the anniversary of their marriage. And on the day that he initiated that behavior with my sister was their anniversary. So just a personal story there to kind of let you know that if we can find out these triggers, it may help us. Also, as embarrassing as this may be for us, versus not talking about it with loved ones, I would encourage you to talk about it. If this behavior is happening and you're concerned, go ahead and mention it in discussions with your loved ones, with maybe the receptionist at the doctor's office or the clerk or the other nurses, any environment or areas where the patient may be in eventually. And also just to your loved ones that support you, so you can get help in dealing with the stress and the frustration and some of the embarrassment. By explaining this ahead of time, if your loved one does exhibit any of this behavior in these environments, that may help alleviate some of the shock and embarrassment overall. You might even just have a knowing look with them like, I told you so, right? And it's much easier. And most people that you explain this to, what I have found is they will completely understand. And you'll find that hopefully you have some more allies and more support as we move along. So redirection and distraction would be the two keys when we're looking at a no-fail environment. And as I said earlier, if that redirection, which a lot of what we just talked about on the prior slide and this slide, if redirection does not work, we might think of switching to distraction. Next slide. So the environmental strategies. Redirection and distraction, I've repeated and I include on purpose here because it's often included as a cognitive behavioral approach, but what we're really looking at is trying to provide that no-fail environment again, right? So the key here is we set up a situation so hopefully we're not triggering any unwanted behavior. And this could include extra confusion or agitation or even aggression in those rare cases. So much of the time it's what we do that elicits that starts that. And that's not to put any shame or blame on caregivers. It's just acknowledgement that this is a very challenging, frustrating process to deal with, and that we want to look at this whole picture of that no-fail environment. So just a reminder of attempting redirection, attempting distraction. So you might say, well, how do I redirect them? Or what am I going to distract them with, right? So we want, in particular to hypersexuality, we want to think about maybe keeping their hands busy, right? We may want to think about keeping their minds busy. And what I have found, and I always encourage for everyone when we're talking about an activity, is can we engage them in an activity that's meaningful to them? If we can engage them physically, but with meaning as well, or I would even say pleasure, something that they enjoy, I have found that the benefits increase, that it does better. So when we're looking at the environment in general, because hypersexuality does involve an overall stimulation to their brain. So if we can decrease that environmental stimulation, it may help. Think of the radio volume, the television volume, even the number of people in a room at a time, or if you're at an activity, is this a crowded room, a crowded waiting room, a crowded store? Maybe we need to pick a different time where it's not so crowded. I have a number of patients that do very well one-on-one or with a few people, and the minute we're in a very crowded situation, I see lots of different behavior because they're getting stimulated, for lack of a different word. And it's not a sexual stimulation, it's a neurological stimulation. But with hypersexuality, that overall stimulation can then lead to more hypersexual behavior. Now, there is clothing out there. If we're in a situation where they are undressing a lot, they are fondling themselves, trying to strip, there is specially designed clothing. Of course, we want to look at snaps and things for day to day, but this clothing is made to be difficult to remove on purpose. Sometimes we're looking at things that have the Velcro in the back or the snaps in the back, different fasteners at the crotch, where sometimes the hip is shaped appropriately, but the crotch is actually in the back. When we're looking at our loved ones at a facility, very often the staffing can affect this. So we might try to keep an eye on which staff members do they flirt more with, or are they focused on a certain staff member sexually, or a certain gender in general. So can we switch that up, and can we involve the caregivers at the facilities as our ally and being a detective to determine that, and in helping us change, make some small changes in the environment. That might include also for the stimulation of which activities they do participate in or don't. And mealtimes, maybe they sit a little more off to the side, etc. As always, it involves kind of using what we do in the nursing process, which is assessment. We take a look first, and then we develop an intervention, an action, but then we evaluate it. Did it work or not? And we keep that process going as we move along. On the next slide, what we're going to take a deeper look at are these activities that I mentioned earlier. So in thinking of engaging activities, this is going to be different for every individual, and it may differ based on their mood that day, and also their level of cognitive functioning, right? Very common ones that help keep the hands busy but engage people could be knitting, crochet, other hobbies that they had enjoyed once, maybe tie fishing, fly fishing rather, the ties, or painting, any hobby that they had loved before. Could also just be helping with chores in the home. Folding laundry is a good one. It may not be folded beautifully, it might be, but at least keeping them active, and it gives them a meaningful activity too, because they know that they're helping in the home. A couple things that I love, and I'll show you in a minute, are fidget blankets and sensory toys. And sometimes I've noticed that loved ones have a bit of an issue using toys with their parents or their loved ones. This is not at all condescending. We are not treating them like children at all. But when we're looking at neurologically what's happening with the brain, and when we're looking at developing an intervention, what we have found is a lot of times these highly designed sensory type toys can help engage them much more deeply and for longer periods of time than other activities. And that's particularly why I like them. Other things that are kind of neat about those two are that you can make them yourself. So if you are a craft person or an art person, or maybe have wanted to try, these are activities that can maybe help with your own stress management and relaxation and creativity as you make your own. And for many persons with dementia, they actually enjoy this activity as well. So it could be a very interesting series of activities that you develop. But really any meaningful activity, that could be scrapbooking, it could be reminiscing, that keeps them engaged and hopefully distracted and redirected from engaging in the sexual behavior. On the next slide, you'll see fidget blankets. These are just two examples. They usually have a lot of buttons, zippers, things that the person with dementia can focus on, can fidget with. Sometimes they'll just have them in their lap and they'll be fidgeting and not really looking at it. And then at other times you'll see they'll be very engaged. There are so many that you can find online available for purchase. Amazon, of course, right? Everyone goes there. Etsy, a lot of the crafts people have teamed up with clinicians, and you'll find a lot of artisans selling fidget blankets on Etsy. And again, by searching online or even looking on YouTube, you'll find videos and instructional tutorials if you did think that engaging in an art activity would be helpful and making one. I can't sing their praises enough. I really love the fidget blankets. And then on the next slide, looking at other types of sensory toys. Some of them are very similar, like the one you see on the left. I wish I had given you a bigger picture, I'm so sorry. This one was designed, everything on that can be manipulated, turned, makes noise, locked, unlocked. Sometimes men really like the ones that look like toolboxes, but there are all types of plushy toys, different toys that the person can manipulate, can stick their hands through, play with. And this goes all the way from just kind of childlike toys, and I would include larger Legos. I'm always cautious about safety and swallowing, but very often we do revert to some of our favorite things from childhood. So it might be some of our favorite toys. And I've personally found Lincoln Logs and Legos to be a go-to that can work for many, many hours. Again, just thinking about the size and safety. But these toys can go all the way to, many of you may have seen the very, very realistic baby dolls, for example. These can often help people, particularly if they've had children, to occupy their time and also help calm them. And just like with the fidget blankets on the previous page, you can make your own sensory toys as well. There are so many of them available for sale, but there's a lot of DIY sites. And we'll be sending out, when Candace sends you the video next week, a resource page with some articles from Daily Caring, but also some great sites to either look at purchasing these toys or making your own. Next slide. So managing the manager, this is you guys. You are the key to all of this, and we know it. So as Jamie mentioned, and as I'm sure Candace at other talks has mentioned, we want to make sure that you take good care of yourselves too. So that might involve relaxation activities for you, learning how to self-soothe in the moment, especially if there was an event with sexuality that was disturbing to you. So learning how to kind of calm yourself quicker and in the moment, you yourself engaging in meaningful activities. And I know you're busy, but not forgetting about physical activity. It's a great way to burn off your own stress, raise the serotonin level, oxytocin level in your own brain, dopamine in your own brain. It helps a lot more. Of course, our own spirituality, using prayer, meditation, and of course, respite when needed and if possible. Then we look at the education and support for you guys. As you know, you're here today, so you know there's a lot in the Jacksonville community, making sure that you don't just get a little 1 hour lecture here and there, but if you feel you need more support, there are a lot of sometimes weekend workshops, many workshops that last longer, offered from reputable national nonprofits. So thinking about getting a little bit more education, or at least more practice with the education. We talk about no-fail environment a lot, but do we really get a chance to practice it? So there are some of these workshops and support groups where it's designed to let you practice doing some of these interventions, using some of this language. Some of these, of course, would be your local Alzheimer's organization. There are also online support groups as well. And there is one in particular, if you'll hit the button, this one is called, I believe, Memory People, Candace, and it is a special online support group. It's primarily only for women at this time, but for women that are dealing with hypersexuality and their loved one with dementia. So I certainly recommend that you pop in and check them out. Then on the next slide, let's review kind of everything that we did together. Medications, they don't all work very well, but some of them have been showing some promise. So we want you to look at making a talk with your primary care doctor or the person with dementia's primary care doctor to see if some of these medications might want to be used. Just want to be cautious about particularly the psychotropic medication and side effects. Of course, the cognitive behavioral approaches that we talked about, really getting good at those skills in the moment, but remembering they may not always work. The best two will probably be the redirection and distraction, which then lead to the environment. And looking at all those different ways that we can change our environment. And of course, the environment includes you, the caregiver. So making sure that you take good care and that you feel supported in this process, particularly with how discomforting sex and sexuality can be in our loved one. So I'd encourage that you do reach out to your primary care provider, or if you have a therapist or a support group. And of course, when Candace shares our information, you're more than welcome to reach out to me if the question is just too sensitive for a group environment for the Q&A at the end. Hope I didn't run over too much, and thank you all very much.
Thank you, Robert. Again, a lot of fantastic information. You know, I'm glad that we can dedicate the time to this. And we now have some time to open up our panel discussion. And that's going to include, obviously, our, your questions, and we can sit and answer them. So if you do have any questions, like I said, if you want clarification on any points, if you want any suggestions on maybe something that you're trying or something that you're not sure if you should try, I mean, you can put it into the chat and we will talk about it. I do want to introduce a couple of additional experts that are joining us on our panel today. Prachi and Doug, if you want to turn your cameras and your microphones on. I want to introduce Doug first. I know that we want to spend some time here in this panel, but Doug, you're an educator with community hospice and palliative care, and you're also a familiar face to our virtual caregiver workshop. So if you would like to take a minute just to share a little bit about who you are and what you do.
Sure. So I'm a licensed clinical social worker. I am the manager of the professional development department in community hospice. That means I'm responsible for the clinical education of our clinical staff, as well as obviously trying to provide education and presentations to the community about end-of-life care, about caregiving. I am an authorized educator by the Florida Department of Elder Affairs in terms of Alzheimer's and related disorders. And I think probably the area of focus that I've spent the most time with in terms of the public, again, has to do with self-care for caregivers and the whole notion of caring for the caregiver. I've been doing presentations for the Caregiver Coalition and on caring for the caregiver for a lot of years now. I've been with community hospice for 15 years. So that's who I am.
Thank you so much, Doug. We're happy to have you here. And then we also have Prachi Rathi, who she is the owner of Prism Health Services. Prachi, let me know she's having issues with her camera, but if you want to turn your microphone on and just take a moment to share about what you do at Prism Health Services.
Sure. Good morning, everybody. I have been an occupational therapist for almost 27, 28 years now, and I've practiced in all sorts of different environments, including home care. So I do know exactly what you guys go through in a home environment. And I am an aging in place specialist. That's what the CAPS stands for. And I have a ton of experience with working with dementia as well. Probably not as much as Jamie. Jamie has been doing this for a very, very long time, but definitely being an occupational therapist, we deal with a lot of activities of daily living and how dementia can affect it and how caregivers can be impacted by it as well. So I'm happy to answer any questions.
Thank you, Prachi. And of course, we have Jamie Glavich and Robert sticking around here to share their expertise on our panel today. So thanks everybody for being here. So I'm going to open us up with a few questions that I had kind of had. You know, I want to backtrack a little bit on some things that Jamie had touched on that I think Prachi would have a lot of really great information on. When we're looking at those common devices that are used in the home, what do you want to look for a loved one to help maintain their dignity and their independence in the home? You know, for example, a loved one who may wake up in the middle of the night to use the restroom without assistance, what are some ways that we can make sure that they can do that safely?
Sure. So there are tons of different options we can do put in place. For instance, there are automatic motion sensor lights. We have a bunch here in our showroom here, but automatic motion sensor lights, which can make sure that the pathway is illuminated when they wake up or when they are moving. There are lights which can be put on their walkers. And again, the walkers, as they start moving it, if they are in a habit of using a walker, that is, and they can remember to use it, that is, then the light will turn on when the walker is moving as well. I prefer, especially with patients with dementia, I prefer that it is wall mounted so that they don't have to remember to do it. It automatically happens. There are other devices which can be put in place, such as like for safety. I recommend always a very low profile but super absorbent floor mats. Which allows, like, if people are having shuffling, as many patients with dementia, they end up shuffling their gait. And if they're shuffling, they may not clear some of the towels or some of the rugs put on. And we want the rugs to be there so that they are not hitting the cold floor, like Jamie was mentioning. So the low profile rugs are safer to be put in place, and even in bathroom or outside the shower, so that they don't trip and fall. But at the same time, they are dry quicker. There are tons of other options. I don't want to continue and take hogging of the entire floor, but one of the other devices we do have is some called the Wander Alert. And with that, it is very unique, where you can put a fence, a geo fence around the house. So if the loved one happens to exit the house, the family member or whoever the caregiver is can get an alert on their phone. And not only that, they can track the person wherever they are with a GPS system. So that is another option available.
Wonderful. Thank you. Jamie, did you have something to add?
No, not really. I would just stress, you can go to Home Depot too. There's some little, always have a night light, and there's some inventions where there's like little lights at the bottom of the plugs. So that creates just a real low light. And I think what Prachi mentioned, like alarms, so that you know that somebody is awake. There's alarms, and there's baby monitors are inexpensive too, to put in the room if you're in another bedroom. That way you can kind of just go to sleep, and then it'll ring you, or you'll hear somebody when they start getting up. Yeah.
One of the other things we have also is called motion detector, where the motion is detected by the device and the alarm goes off for the caregiver. It's not closer to the person, because sometimes the alarm going off closer to the person with dementia, it can agitate them, and that is also indignifying for them as well. So many a times I've noticed that if you can do it discreetly, it's much more easier for them to handle.
Mm-hmm.
Wonderful. I'm taking notes here too, so I can make sure I share all of this information. So thank you, Prachi and Jamie. What are some important and common things that you want to consider when you're choosing the right incontinence products? Jamie, I'm going to direct this to you with your experience in the assisted living.
You have to, it really goes on how often they're still toileting by themselves. If you just need, there's so many products, there's like almost menstrual pads that you can give somebody's just dripping a little bit and they know they have to go, but they make it to the toilet in time. And then the pull-up briefs that are like underwear. And again, they make them in all colors now to be discreet. But those are for somebody who, is just starting to go a little bit, having a few accidents, but it's not, if they're totally incontinent, those will not absorb enough. So you want to get the full briefs with the tabs on them that are going to be thicker and be able to hold more fluid if somebody's totally incontinent. And if somebody is hard to change, and if they're kind of aggressive when you're trying to change their brief in the bathroom, you might need to use something with tabs because it's quicker and easier. The drawback on the pull-up is that if they do get it wet, you have to take all their clothes off in order to change it. So that's another consideration if you're trying to get in there and get somebody changed quickly, because they're going to get upset that you're in their personal space. You're going to try and do something as quick as possible.
And if I could just add one other little thing, certainly in working with our nurses and our CNAs, what I hear a lot, that's probably an important reminder, is that the whole issue of sizing and fitting is very, very important and can be complicated and difficult, not only for, including for the professionals who do this day in and day out. So as a reminder to caregivers how important the whole notion of fitting and sizing for incontinence products, very, very important. And I never would have known that as a social worker until I became involved in training and educating nurses.
Yeah.
Hear it all the time about how crucial that component is to the whole incontinence product. Is that right, Jamie? Yeah.
Absolutely. And if it's not tight with the tape and the tabs, then it's going to leak out. Yeah. And really the prevention, intervention, do the toileting routine every 2 hours. You know, that really will be a big savior too on getting wet furniture or having them just disrobe to go to the bathroom. Yeah.
If I may chime in, there is other products out there. You know, a lot of my folks, my clients, who they call it astronaut underwears, and they truly, that is what they are. That is what it's made with NASA technology, actually. And the reason I prefer that with a lot of dementia clients of mine is because it allows the caregiver, number one, to be able to do other things and not have to worry about changing them every 2 hours. And it keeps the person dry. So there are many of them who have given me reports that they are now, especially the caregivers, are able to sleep through the night because now the underwear is absorbing, or the briefs are absorbing so much better and keeping the person dry. So it's avoiding the UTIs, no smell at the same time, the person is dry. So it's more beneficial. And the other thing, like Jamie was mentioning, that if you don't have to go into their personal space more frequently, it's much easier for them to handle that as well. One of the other things which is also available now is the normal looking underwear, because many of the patients with dementia or the clients with dementia, they don't want to wear what looks like, which doesn't look like a normal underwear. And there are underwears which have built-in absorbent material and which looks like a normal underwear, and they are more accepting of that. Especially men, I have noticed that they tend to have a little bit of an issue with any pads.
And there are some specific ones made for men and women
Correct.
too. So talking about fit, that's another thing to look
Correct.
at, making sure you're buying the right one. Yeah.
Absolutely.
That was another question that I wanted to direct towards you, Prachi, is what are some, common devices? I know that underwear could be one of them, but assisted devices or, modified clothing that you could use, or what's the best way to introduce them to a loved one in maybe a way that doesn't alarm them or offend them if they do want to feel like they really are, maintaining their independence and their dignity? How do you communicate that? How do you introduce that?
Right. So typically, again, just like Jamie in her lecture said, or in her presentation said, that don't confront them. So it's not, wise to confront them. If you can, if they are, able to have a conversation, it's best to, consult or, include them in the conversation. But if they are not able to have a proper conversation, sometimes it is best not to confront them. I'll just share a story which I think I had shared with Candice a while back, where it was easy for the family to put in one of the underwears in their underwear drawer and not even talk about it. And the person, when they were getting dressed next morning, they picked up the underwear, put it on, didn't know the difference, and they went about their way. And next thing we knew that since that a new underwear was able to control the leakage better, the wife then gradually just changed the whole drawer full, and now the whole family was happier. So sometimes it's better not to confront or argue with them. It's just like I said, discreetly just do it, and everybody's happy that way.
Agreed. Yeah.
Thank you. We had a question in the chat, and I'm pulling up, I think this is the slide that was being referred to. They said on one of the first slides, there was one about meals. One point was the food versus the plate. I think this is the slide that you were referring to, and this was part of Jamie's presentation.
Okay. They were asking about plate specifically. It really helps so that they can see. Now, with aging, your eyes change anyway. You see shadows. You need something very back to the primary colors. So really, I've actually changed and did my own little research, but by changing to dark plates, like a red plate or a dark blue plate or even a black plate, the food actually pops out and you can really see it a lot better. So it's just an example. You wouldn't want to give a white plate there were shows in nutrition classes, putting white fish, mashed potatoes, and a white piece of bread on it, because then the person can't even see it. So by putting that, getting an inexpensive change of just doing a plate really helps the eating experience, because they're actually able to visualize what's food on there. And I use the melamine food because they do get to the point sometimes where they take that plate and they might shove it across the table, not being mean, but just like, I'm done, and throw it across. Some other things that we do use, there are adult, and for lack of a word, kind of a sippy cup. You can get a cup with a straw in it, which helps for a long period of time. They can do the sucking motion. Now, when they advance, sometimes it's hard for them to suck on a straw because of the swallowing issues. But a lot of times they will drink more because they have that straw in there. And the more you can keep them fluidized, I call it, or keep fluids in them, it's going to be really helpful. Another thing with food too is use spoons a lot. That scooping motion. Actually seen people stab themselves with their fork by accident. So the spoon, and you just kind of get the spoon, and they have got that scooping motion. It's a lot easier.
If I may add, there are a lot of more other options, like there is a special plate called the scoop plate, which has higher, or even the inner lip plates, which allows the scooping function easier. There are plate guards. There are, a lot of different options. Again, the idea is to keep them as independent as possible. And if they can feed themselves, all of us, even as adults, we find joy in feeding ourselves. When we were kids, our children, when they were growing up, the first spoonful they could take without somebody's help, that was such a proud moment for our children, us. So similarly, seniors also, they would have much more dignity if they were able to feed themselves. And there are tons and tons of feeding implements and drinking implements available that can keep them safe. There are some spill-proof cups, so that even if they by accident drop it, or put it sideways, it doesn't spill. So that kind of contain, again, maintaining their dignity.
Thank you. So another question that I had, and I'd like to direct this question to Robert. We're going to kind of segue to that last part of our presentation. But Robert, I know often some behaviors, we may not consider them difficult or noteworthy if they are, manageable. But at what point should a caregiver consider sharing with their physician about any kind of difficult or inappropriate behaviors?
That is such a great question. My answer is going to probably seem really simple, but any time is the right time. If something is concerning to the caregiver, I would say, let's bring it up with the provider, the physician. And I would say, even if it's not necessarily concerning, because sometimes we do get a little acclimated, we're kind of used to the certain quirks of an individual or their behaviors, and then we may not think that it's something to report to the provider. But any small change can actually be indicative of other things. And I'd love for us all to be in good communication and good touch, not to be alarmed per se, but to just be in that habit that this is what we do now. We pay attention, we share with our provider, and I'm always hopeful that, that you're, whenever you are in this situation, that you do have a provider that listens. And I always encourage people, if you feel that they don't listen to you or make time for you, remember there are other providers in your community. My best friend is a physician, and she always says, "Why do you say that?" And I told her, well, you're a wonderful physician, Kat, but sometimes a practice is not set up to really give the family and the loved ones that they need. So I always just remind people there are other providers out there, and most of them, although it's a challenging environment in today's economic world, they will listen to you, they want to hear from you, and they want to partner with you to find solutions. So if, circling back to the original question, if there's a question, a concern, even a curiosity, I think sometimes we're embarrassed a little about our own naivete or maybe about our own curiosity. I would say ask that clinical partner for sure, whether it's the provider or the nurse that you get along with, or someone at one of the amazing organizations, that are in Jacksonville. ask someone?
You know, caregiving can be stressful and exhausting enough on its own. And to have to spend 2 weeks wondering and worrying about something is unnecessary additional stress in the process. So I completely agree with Robert. Ask the questions, communicate, get information as soon as it comes to your mind, because you've got enough things that are going to be exhausting and stressful and overwhelming to deal with.
And that's a great point that you made, Robert, about, you know what you need as a caregiver, and you know what your loved one needs in terms of care, and you can be your own best advocate as well as your loved one's advocate. If there's something that you need and you're not getting it, there are other physicians out there. There are other resources out there, and you aren't necessarily stuck with who you're with or what you're doing.
I've often found, especially like my parents of a certain generation, so from World War II, but the Korean War forward, so many older adults think it is rude to ask a question of the provider, or even to communicate in what I would call an assertive way. They equate being assertive with being aggressive, and so just to remind everyone that we all have needs. Needs are human and they're normal, and we are not only allowed but encouraged to express ourselves in a way to get our needs met that is respectful to the other party. So asking a question is not disrespectful to a provider. And if that provider behaves as if it is, I'm going to tell you to switch. That is not a provider you want to be with. Yep. There's not a question in the world a client could ask me that I would be offended by. That's just me personal. But certainly if it's an appropriate question, like, tell me again why we're on this medication, or I'm sorry, what was that term you mentioned? That's okay. So, and we know that very often when you are in the office, you do forget to ask questions, even if you want to, so I always encourage people, write down that list, but if you do forget, certainly contact them back. But assertive is not aggressive. It's not rude. And I think my mom said, I'm blanking. I have a little bit of forgetfulness this morning. There was a funny expression about to basically normalize getting your needs met. And it's something about a dog who needs water, and if he doesn't bark, something. I blew that one. But clearly it's okay to state your needs and request information or help.
Yeah, it really shows that you care too. It is showing that provider that, oh, this is a caregiver that cares. And a lot of times it opens the door for them to explain more too, because they see that the family is really interested. That's one of my experiences. But Robert, thank you for saying that. If the doctor or the medical provider is not meeting your needs, please get help somewhere. Go to another one. Yeah.
One of the other tricks I'm going to share for families who want to ask questions and they tend to forget, if you have those appointments written down in your phone calendar, there is a notes section. So as and when you are remembering your questions, just start putting them down in that same appointment section. That way, when you go to the doctors, you have all of your notes right there in front of you.
That's a great suggestion. Jamie's suggestion about having that caregiver journal where you can list any behaviors, anything that you've tried, and the results of that intervention. Between those things, I think that you will definitely be prepared when you have that doctor's appointment, when you see them. I got a question in the chat. I know we just have another minute or so left. But they said, I care for someone who thinks people come into his room and steal from him in the middle of the night. It's not happening, but he is fixated on this. Any advice on changing this? I want to open this up. Doug, I know that you have a lot of suggestions for different redirections and managing difficult behaviors. I'll give this to you first, Doug.
Well, suspiciousness in general, and let's, because both Jamie and Robert have mentioned this, and you probably can't emphasize it enough. It's really important for caregivers to remind themselves that behavior is communication. in one way or another.
Mm-hmm.
And so what we're trying to do as the caregivers is learn how to interpret the behavior in terms of what it is communicating. So even suspiciousness or paranoia is almost always behavior of that nature is almost always communicating something. Anxiety, and it could be, related to all kinds of things that the person is experiencing. But the question that really becomes, what can we interpret that behavior to mean for the particular person that we're caregiving for? So, reassurance. Are there some changes that you can do to the environment that may help that person to feel a little safer? Reminding them we've put alarms on the doors or windows. Are they going to remember that forever? No, of course not. But that reassuring, calm approach to things, and trying to understand what it could be that is being communicated by that suspiciousness or that paranoia, and doing the reassurance in as calm and reassuring a way as possible is at the very least going to help for a period of time.
Yeah, I totally agree. And I think in these scenarios, obviously a little more information is important, but assessment is the key, like I was mentioning earlier. So I would want to know things like, have they misplaced their wallet? And that's why they're saying that, because based on what's really happening is how I might base an intervention. Or are they just thinking someone's coming into their apartment, or are they actually seeing it? Which could be an illusion. That's when we misinterpret something we're really seeing. And we know there are these significant changes in eyesight, depth perception with dementia. Or could it be an outright hallucination? Or is it just, what we would call delusional, a fixed false belief that's not really happening? And based on what's really going on, we can do any number of gentle interventions. One time we had this similar scenario. So we got like a child safe, like from a toy store, but it was lockable. And so the person got to put his wallet in there, and boy, he felt like, it was like Fort Knox, but it was just a child safe. Another woman thought, that this man was coming into her apartment, etc. And after a lot of discussion, what the family chose to do, and I supported it, it was a little risky, but she had certain spiritual beliefs about fairies and spirits. She was from Ireland. And so the family chose to say, yeah, they are visiting you. These are the fairies and the spirits, and you're being blessed. She was so happy and calm. And now she wasn't scared. So of course, I'm not seeing fairies when I go to her house. Her family's not seeing fairies, but guess what? She's not distressed anymore. And as a psych person, we're always taught reality reorientation, don't go into the delusion. And I'm here to tell you that sometimes, particularly in scenarios with dementia, you must. And we've got to be willing to be a little loosey-goosey. Again, I would, if you're going to choose that as an interventional strategy, I would check with a professional first. So you get kind of used to weighing. I'll be honest, there are physicians and nurses that call me like, hey, I'm thinking of doing this. And we review it together. How far on that limb do you want to go? There are certain times, particularly for safety, that we want to be very clear with reality reorientation. But there are other times where it's just going to create more conflict and suffering. And so if we can allow mom to believe there's fairies and she's happy, go for it.
There's a way to frame it in a way that's comforting, than being comfortable in living in their reality in a way that can be reassuring and comforting, then why don't we do it? Yeah, great point.
Absolutely. Thank you. I want to take one last question because I feel like it's really relevant. So if we could just take a minute to answer, we had a question in the chat. about what recommendations do you have for loved ones who try to remove their adult briefs during the night?
Okay, this is very, very common, and I had written this note down too a few minutes ago. I have come across an adaptive clothing site, and Robert talked about adaptive clothing too. It's Buck and Buck, B-U-C-K and BUCK.com. They have clothing on there, and you can go in for adaptive clothing or type in Alzheimer's clothing. And then for men and women, they have very discreet looking pants and tops, whether they're sweatpants and sweatshirts or decorative, more dressy type of items with the zipper or Velcro in the back. So somebody who's disrobing in public or disrobing at night, or when you start getting them advanced where they're doing the digging in playing in the private parts, then you need to put something like that on that's going to protect them against infection too. But they're anywhere from $30 to $45, but washable, well worth the investment to at least have one on standby, just so when that problem starts to occur. Very, very helpful. Another quick thing, another really good, helpful thing to have around the house is one of those little sound machines that you can turn on for the ocean or for birds chirping or crickets or rain.
White
And
noise.
those are, right, all that kind of noise, white noise too, yeah. So, and they're really helpful of trying to get somebody to go to sleep. Sometimes music doesn't always work because they want to either get up and dance or it doesn't soothe them as much as maybe listening to the ocean or listening to the birds, go on at night, or crickets. So that's a good, inexpensive, kind of helpful thing for families to have around.
Thank you, Jamie.
Sure.
I know we're a little bit over our time. I'm looking up that website. We had a question about the spelling, and it is Buck and A-N-D, Buck.
Yes.
So everything that was mentioned, any websites or resources, like I said, I was taking notes, so I'm going to include any links in the follow-up email, anything that was referenced. I'm going to do my best. I'll rewatch the workshop and make sure I didn't miss anything, but I'm going to put that in the email in case there was something that you missed, because I know that there were a lot of really fantastic suggestions that we talked about today. And so I'll be sending that out next week along with these slides and with the workshop recording. So since we're a little bit past our time, I'm going to close this out. But if there were questions that you had that you didn't get the chance to ask, or that we didn't get the opportunity to cover, you can email info@caregivercoalition.org. Those emails come straight to my inbox. And if I don't have the answers for you, I will always try to connect you with the resource that does. That's really, a big part of what we're about with the Caregiver Coalition, is making sure that you're connected to the resources and the support that you need. So you can email info@caregivercoalition.org, and I will do my best to answer you. And we'll be sharing the information from our speakers, Prachi's website, Jamie's book. We'll be sharing that information afterwards as well. So to close us out, I am going to launch a very short, it's going to come up on your screen. And this is just something that helps us make sure that the content that we're creating, the workshops that we're planning, are relevant to you. We want to make sure that what we're doing is really serving you in the capacity that you need as caregivers. And if you want to stay in touch with us, there's a QR code that is on the screen. You can open the camera app on your phone and it'll scan that code and come up with a little pop-up link at the top. And if you go to that link, it'll open up the link to our website, where we share local resources and caregiving events all throughout the community. It gives you our Facebook that you can follow, our YouTube channel where you can subscribe and watch the recordings of our virtual caregiver workshops. And there's also a link to sign up for our e-newsletter. And I just send out regular emails about activities and events and do my best to keep you connected with this incredible caregiving community that we have here in Northeast Florida. So I want to close this out with another big thank you to our expert panelists for sharing their time and expertise and making today so meaningful. So Jamie, Robert, Doug, and Prachi, thank you so much for being here.
Great job, Candace. Thank you.
Thank you. And for everyone else who joined us by phone or by computer and participated in this discussion today, thank you for being here. Keep an eye out next week for the workshop recording. and the slides. And I hope you all have a wonderful weekend. The weather here is supposed to be beautiful. So do something fun,
Nice.
something relaxing.
Bye, everybody.
Thank you.
Bye, thank you.
Bye.